So coming to the hallmarks, the main hallmarks. So usually we find that there are two characters of the hallmarks, that is the enabling characteristics and the emerging characteristics. And among the enabling characteristics, we see that for a cancer to occur, usually the genomic instability and mutation are the most important character. That is, for a mutated cell to continuously proliferate, it must carry the genomic instability as well as the mutations. It could be a gene translocation, gene amplification, gene deletion, or otherwise the overexpression of the gene. These all abnormalities at the genetic level and epigenetic level constitute the enabling characters for the mutated cell to proliferate. So enabling replicative mortality means it means that the cells which have been mutated, they start continuously being replicating. They start multiplying in an uncontrollable manner. That is, their death cannot be enabled. Rather, it can be progressed into formation of a mass of cells, and increasingly this multiplication is very rapidly occurs at a very high rate of growth. So coming to the next hallmark is tumor promoting inflammation. Usually they have been observed that in certain studies they have observed that host system which shows its immune response, because which initially tries to damage the tumor cells which are trying to attack the body. But this is not happening. With this, tumor cells have become so resistant to even the immune mediated cells that they do not die, rather they progress. So by this, they have identified that certain cells, the cells which are supposed to act as a defensive for a body, they have been associated with this tumor cell. So this is also one of the hallmark for the developing cancer. Coming next is activating invasion and metastasis. As already described, invasion and metastasis, they are the most characteristic features for a malignant tumor, which are being brought about by the developing tumor cells in a series of manner by altering the basement membranes at the tumor, the extracellular matrix as well as the capillaries, and these metastasis can be carried through lymphatic spread or hematogenous spread or translumic cavities or transimplantation or through epithelium. This is what happens in active invasion and metastasis. And inducing angiogenesis. Since tumors start growing into the blood vessels, they attain the angiogenesis, that is the proper blood supply, and as well as they as secondaries, metastatic tumors as secondaries, they get adapted to the environment of the host, which is usually supplied continuously with proper nourishment. This is what happens in inducing angiogenesis. Next, coming to the other emerging hallmarks, that is the avoiding the immune destruction. That is, they become resistant to our immune system. So, which makes them allow them to replicate normally as in a host. Coming to resisting cell death, that is, they prevent the process of apoptosis because of inactivating the pro-apoptotic factors and activating the anti-apoptotic factors. Coming to deregulation of the cellular genetics, that is, since the genetic basis is completely being altered, the expressions, and they also associated with them with the protein metabolism. So this becomes the emerging characteristic feature of the cancer. This is what happens. And sustaining the proliferation signal, that is, they continuously proliferate because of the presence of inactivation of the proto-oncogenes and anti-oncogenes and the presence of activation of the oncogenes. This is what happens in hallmarks of cancer. Coming to the carcinogens, usually we find that the carcinogens usually a patient might be either an immunocompromised patient, or otherwise usually because of the hereditary factors, they might cause the carcinogenesis in a patient. Coming to the different types of carcinogens, among them most important is the chemical carcinogens. Usually chemical carcinogens, they are of two types, that is the direct acting carcinogens and indirect acting carcinogens. Directly acting carcinogens, they directly affect the host. They do not require any metabolic activation, whereas the indirect acting carcinogens, usually since they directly cannot affect the host cell, so they have to become metabolically they have to activate themselves into active carcinogens. That is, they transform from indirect carcinogen to an direct carcinogens. Among them, examples of direct carcinogens are alkylating agents and acylating agents. Alkylating agents can be given an example of chlorambucil, as well as acylating agents can be given an example of imidazole. So these directly carcinogenic, direct carcinogens usually cause a direct effect to the they cause effect to the DNA. Whereas indirect carcinogen, indirectly acting carcinogens, they usually first get transformed metabolically into active carcinogens. This activation occurs in the endoplasmic reticulum under the under a pathway of P450 system, which consists of a monooxygenase enzyme which is being secreted by the liver. This monooxygenase enzyme which is being secreted by the liver is a part of is a part of this enzyme system which activates the inactive carcinogen into active carcinogen. Once this gets activated into an active carcinogen, it is known as reactive electrophiles. This reactive electrophiles have affinity to only go and cause the damage to the electron-rich molecules. Among them, in our body, if we find electron-rich molecules, it is the DNA. It consists of an electron-rich molecule, so they form the DNA adducts. That is, they damage the DNA by altering the DNA expression or the causing the deletions of the DNA or the translocation of the DNA or the genetic materials of the chromatids. This causes, this results in a mutated cell. This mutated cell is further being promoted. This promotion is being brought by the promoter carcinogens. These promoter carcinogens usually cause the multiplication of the mutated cells and maintaining the proliferating pool of the mutated cells and further helping the developing into a tumor mass. This is what is occurs in chemical carcinogens. So chemical carcinogens is being mediated by initiators and promoters. Initiators will initiate the process of carcinogenesis, promoters which maintain the process of mutated cells and their population. So promoters themselves cannot bring the mutations, but whereas initiators, they can themselves bring the mutations. Coming to the differences between promoters and initiators, promoters, they are not mutagenic, but rather they maintain the environment of the tumor cells, whereas initiators, they bring mutations and they cause sudden changes and rapid changes, whereas promoters, they bring slow changes. For one mutated cell in a chemical carcinogen to become a carcinogen, it has to go at least one cycle of cell division, which becomes into a stable mutated cell. This is what happens in chemical carcinogens. Coming to the indirect chemical carcinogens, they are the polycyclic aromatic hydrocarbons and the amines and the dyes. Amongst them, the dyes, they are the common coloring agents which are using as a food coloring products. They could be saffron or certain amines, or otherwise the naturally occurring substances which occur because of the in the industries, or otherwise the smoke or the pollutants. They are the naturally occurring chemical carcinogens in our body. Coming to the process, what happens in chemical carcinogens is, first, when the patient is being exposed to a carcinogen, this being absorbed by the human tissues, and this gets distributed throughout the host system. Then this is being biotransformed. This biotransformation involves the activation into a inactive carcinogen into the active carcinogen. Otherwise, the active carcinogen being showing that as active carcinogen has a direct potentiality to damage the DNA damage, it brings the genotoxic mechanism. Genotoxic mechanism induces DNA adducts, that is the that directly causes some mutations in the DNA genetic material, and this causes the transformation into a genomic damage and brings the mutated cell that divides and causes cancer. But whereas we see in an inactivated carcinogen which is being first activated, that is the biotransformation occurs, then it brings about non-genotoxic mechanisms, that is it can bring inflammation or immunosuppression in the host, and then it causes altered signal transductions, that is the alteration in the cell regulating pathways, that is it sustains the prosperity of apoptosis, that is it does not drive the mutated cell to apoptosis, otherwise it prevents the damage of the DNA to be repaired by the tumor suppressor genes or otherwise the rat sarcoma genes, and then drives it to cancer. Otherwise, if this non-genotoxic mechanisms, they can also drive the drug to infiltrate by the kidney and the liver. This is what happens in chemical carcinogens. For this chemical carcinogenesis to occur, there are two main important properties which have to be maintained. One is the levels of the genetic levels for the activation and inactivation of the carcinogenesis, and others is the genes which regulate the process of the activation of the inactive carcinogen which occurs in the liver by the monooxygenase enzyme. So based on these two regulating processes, only the chemical carcinogenesis can occur. So this is what happens in a chemical carcinogenesis. Coming to the physical carcinogenesis, physical carcinogenesis can be of two types, that is the ionizing carcinogenesis or the non-ionizing carcinogenesis. Ionizing carcinogenesis are usually harmful to the host, but whereas non-ionizing carcinogenesis, they are not harmful. They are because of some traumas or otherwise physical injury, because of formation of stones in our body, which could be said for example in a layman language as a kidney stones. These are the non-radiation physical carcinogens which usually and which rarely cause the carcinogenesis in body. Coming to the ionizing carcinogenesis, they are of two types. That is, further, they are the ionizing radiation and the non-ionizing radiation. The non-ionizing radiation includes the UV radiation. This UV radiation is most commonly seen in patients people who are mostly exposed to increased sunlight or otherwise in regions such as Australia and New Zealand, which are placed nearer to the equator with more sun exposure. These are usually UV radiations, they directly cause the damage to the DNA. But usually this UV radiation can be controlled by a host immune response, which is being controlled by the melanin cells which are present in the skin. So once that melanin cells can control this UV radiation, it can drive the DNA damage cells to death. But if this cannot be controlled, it continues and results in genomic instability and results in the formation of evading apoptosis. That is, the apoptosis is being evaded, that is, it cannot be driven to the apoptosis. Rather, the mutated cells, they continue to progress and they become insensitive to anti-growth signals, that is, they're not being controlled by the anti-oncogens or the tumor suppressor genes. Rather, they provide growth factors themselves. As we know, the tumor cells, they have a property of producing growth factors themselves, which attain them to a self-sufficiency growth, and rather this results in proliferation of these tumor cells, that is, they are being transformed into uncontrolled growth because of the absence of the proto-oncogenes and tumor suppressor genes and the presence of the oncogenes, and they form a sustained angiogenesis by the host. They can derive from the host as well as they can develop by their vascular endothelial growth factors and fibroblast growth factors, which can sustain the angiogenesis in tumor cells. Otherwise, they can also invade and metastasis, so that is with the progression of the malignant tumor. This is what happens in UV radiation if the DNA damage is not being controlled. And coming to the ionizing radiation, what happens is directly coming to the ionizing radiation, usually it has two properties, that is, it can directly cause the alteration of the DNA, or otherwise it can cause the formation of reactive free radicals in the form of reactive oxygen species or otherwise reactive nitrogen species. These are formed by the removal of hydroxyl ions from the water. So this radiation shows its effect by removing the hydroxyl ions from the water molecules or other metabolic reactions, resulting in the formation of the most harmful substances, that is the free radicals. These together, they can cause the DNA damage and cause the genomic instability, and they cause the continuous formation of the mutated cell, which goes through evading apoptosis and insensitive to anti-growth signals and sustained angiogenesis, and then invading continuous invasion and metastasis. This is what happens in physical carcinogenesis by the UV radiations and the ionizing radiations. Coming to the biological carcinogenesis, usually we see that there are biological carcinogenesis also in our which can cause carcinogenesis in our body. Among them, if we see a fungus usually it is rare in a fungus, but it can be an Aspergillus species can cause even a fungal carcinogenesis. Even in bacteria, similarly, there are certain carcinogenic agents which can bring about the carcinogenesis in humans. And the most important batch or the most important group which can bring carcinogenesis among the biological carcinogens are the viruses. They could be DNA virus carcinogenesis or RNA viral carcinogenesis. So what happens in the DNA viral carcinogenesis, and the process is usually it happens in a stepwise fashion. Well, as we know that the DNA virus, it usually does not function extracellularly, but it gets integrated into the host cell and then performs its function. So for it to function, it should first reach the integrator. It should get integrated into the host cell. From the host cell, it should reach the nuclear environment. That is, it reaches to the nucleus, and there this viral DNA, it gets incorporated into the host cell DNA region, where this gets once this viral DNA gets incorporated into the DNA, it starts associated with a T expression. That is, a T cell, T or T antigen gets expressed. This indicates that the virus has started showing its harmful effects on the host cell. So once the T antigen gets expressed, it shows it can be divided into two stages. Either it can directly cause the viral DNA replication and cause the new formation of new virions, which cause the damage to the host cell and continuously cause the damaged DNA, which continues to proliferate in the host cell. Or otherwise, it can also cause the integration of the viral genome and form the neoplastic cell transformation. This is what happens in case of DNA viral oncogenesis. Coming to the RNA viral oncogenesis, usually the RNA virus, it constitutes of envelope proteins as well as RNA, that is a RNA reverse transcriptase enzyme, that is which synthesizes a template which is similar to that of the DNA strand of the host cell, and also it consists of the provirus proteins. That is, the once this RNA virus entire envelope, along with the envelope protein and the enzyme and as well as the strand, it gets incorporated or integrated in the host cell. It starts synthesizing it, showing its effect. That is, it forms a complementary strand of DNA with the help of reverse transcriptase and synthesized enzyme. This enzyme, it forms a template, and this template along with this RNA envelope genes, it forms the provirus. This provirus, it integrates into the host cell, that is in the host cell genome, and there it transforms the whole cell, because the virions, that is the provirus, along with the DNA genome, both of them, they get together, combine, and results in the formation of mutated DNA, which continues to proliferate and results in the formation of damaged DNA or mutated cell, which proliferates rapidly and results in the formation of RNA carcinogenesis. This is what happens in RNA carcinogenesis and DNA carcinogenesis. Coming to the one of the chief example in humans, which is being caused by the hepatitis B virus, resulting in the development of hepatocellular carcinoma. Usually we see that the hepatitis B virus, it is usually associated with chronic infection in a host. This chronic infection causes chronic inflammatory response usually. That is, the manifestation of the hepatitis B virus infection in a host is usually occurs with the help of chronic inflammatory reaction. This chronic inflammatory reaction mainly targets the liver. That is, since these viruses have an affinity to go to the liver and therefore replicate, this starts liver regeneration. So along with that, there is also, since a virus, as we know, DNA, we have seen the carcinogenesis of the DNA virus, that's get incorporated into the DNA viral genome and then correlates to the DNA virus and as well as the viral genome. Both of them combine and result in the DNA damage. So we see that there's genomic instability because of this viral integration into the host genome. Then this results in the formation of inactivation of the tumor suppressor genes, the genes which actually control the damaged DNA to drive it to apoptosis. So there's inability or inactivation of this tumor suppressor gene. So by this, there's this mutated DNA damage continues to proliferate, and this proliferation causes the activation of the cellular genes, that is the transactivation of the cellular genes occurs, that is the oncogenes starts functioning, that is they promote this damaged DNA to continuously proliferate and result in the formation of carcinoma, that is hepatocellular carcinoma. This is what happens in hepatitis B virus induced hepatocellular carcinoma in humans. So coming to the set of DNA oncogenic viruses, the most common viruses, and they in humans most commonly is a human papilloma virus, which causes cervical cancers as well as pre-cancer lesions. Usually the most common cancer is a squamous cell carcinoma, and then it also causes in skin cancers as epidermodysplasia verruciformis. This is one of the tumor, and otherwise there are papillomas which occurs as common warts on the skin, or otherwise as genital warts when it involves the genital layers, and these warts can involve the larynx region. And coming to the other set of genes, that is the SV virus, SV40. This causes the mesotheliomas. Mesothelioma is a tumor which is caused by SV virus 40. And coming to the Epstein-Barr virus, these are the most common virus which could cause Burkitt's lymphoma or the nasopharyngeal carcinoma in the humans. Coming to the other set, that is a human herpes virus 8, otherwise known as human papilloma virus 8, HHV8. They cause possess sarcoma, which is the most common herpes virus causing the oncogenic virus in human, and the other one is pleural effusion lymphoma, is also other kind of DNA oncogenic virus causing tumors in the humans. And the other ones are pox virus causing molluscum contagiosum, and the final virus, as we have already discussed, it is a hepatitis B virus causing hepatocellular carcinoma. Coming to the RNA oncogenic viruses, they are grouped into acute transforming viruses, slow transforming viruses, human T cell lymphotrophic virus, or the hepatitis C viruses. They are among the acute transforming viruses. The first virus is a Rheosis sarcoma virus, which causes the sarcomas, and this next set of viruses is a leukemia sarcoma, which causes the leukemias as well as the sarcomas. Coming to the slow transforming viruses, they are the mouse mammary transfer virus, or the tumor which has been observed first in the mouse. So it has been so termed. It causes leukemias, lymphomas, and breast cancers in the mouse. Coming to the important set of groups, that is the human T cell lymphotrophic viruses. These are the only RNA viruses which cause cancers in humans. They are of 4 types. HTLV are of 4 types, but among them the type 1 and type 2 are most commonly the other common viruses which are observed in humans, causing a type 1 which causes the adult T cell leukemia lymphoma, and the second type 2 of human T cell lymphotrophic virus is a T cell variant of hairy cell leukemia. These are the most common viruses which commonly occur. And the other one is hepatitis C virus, which causes hepatocellular carcinoma, which is the least common. These are grouped as a RNA oncogenic virus. So there is difference between the acute transforming viruses and the slow transforming viruses. These acute transforming viruses, usually they cause a rapid changes, whereas slow transforming viruses, they usually take a lot of time to start manifesting in the body. And coming to them, usually these RNA viruses are composed of 3 set of genes. One is the GAG gene, envelope gene, and Pol gene. These genes are respectively, they are involved in the formation of the parts of the RNA genes, such as envelope genes. They are involved in the formation of the envelope proteins. That is, then the Pol genes, they are involved in the formation of the polymerase enzyme, which helps in the formation of transcriptase, that is a complementary DNA strand. Other than the genes, there is also an exceptional genes which is seen in HTLV1, that is a TAD gene that forms the activation of the oncogenic virus. So these are the set of genes which most commonly bring about the carcinogens in humans. So this is what biological carcinogens is. And now coming to the tumor-host interrelationships, usually naturally coming to the history of neoplasm can be based on and can be explained based on 2 features. One is the host immunology of the host, immunology of the cancer, and second one is the effect of the tumor on the host. Starting with the effect on the tumor on the host, usually we see the tumor starts showing its local effects as well as certain effects on the tumor. Coming to the local effects, usually since the growth of the tumor in malignant tumors is usually rapid and it is rapidly increasing in growth, it might cause compression of the adjacent tumors, or otherwise it might cause obstruction of the tumors, or it might cause even emboli, that is dislodgement of this tumor can cause the obstruction in the normal regular flow of the lymph or the blood or the other body circulating fluids. These are the local effects which cause the being caused in a host cell. And they come into the other effects are cancer cachexia, that is anorexia along with asthenia are the two properties which can be seen in cancer cachexia. That is, cancer cachexia means wasting disease. Asthenia, that is asthenia and anorexia, that is we see that the patient starts developing unexplained fever in the body or otherwise unexplained weight loss because of loss of appetite. Cancer cachexia is a condition which involves asthenia as well as anorexia, where we see in patients with an unexplained wasting disease, that is a loss of appetite, which is associated with loss of appetite, weight loss and unexplained fever, are these conditions which can be seen in cancer cachexia in case of local effects of the tumor on the host. Coming to the next is a group of conditions together which show the paraneoplastic condition. It is also an effect which is being shown by a tumor on a host. That is, a group of conditions occur which with unexplained reason in associated cancer or progressing cancers. It could be given example of endocrine abnormalities like hypercalcemia or hypocalcemia, or in bones it could be clubbing of fingers, or in the kidneys it could be improper filtration. Various such conditions have been observed in case of paraneoplastic condition. These are the effects of the tumors on the host. Coming to the immunology of the cancer, usually host response against this, nothing but host response against the tumor, as a body consists of immune response which fights against the foreign bodies or pathological organisms. Usually also in cancer also, a body actually tries to fight against these tumor cells, but so because of certain reasons these tumor cells still resist all these immune responses and continues to progress. But certain findings previously have led to concept of immunology of cancer, and these findings was usually cancer does not occur in highly resistant organs such as spleen. Usually it is impossible for any tumor to occur in this organ. And coming to the second finding was that presence of certain immunocompetent cells in tumor areas. That is, these cells must have tried to fight with the tumor cells, but they must have not prevailed. Rather, tumor cells must have prevailed. So this was also a finding. And coming to immunosurveillance, that is a host immune response which is involved not only in removing the pathogenic organisms, foreign antibody and debris, but also tries to remove the tumor host cells. This was another finding. And coming to another finding, in malignant melanoma, usually the primary tumor is not being observed, but the secondaries can be observed. That is a secondary, that is a metastatic part of the malignant melanoma has been observed. So based on all these findings, they have come to a concept of immunology of cancer. That is, immunology of cancer might be existing in a host that which might try to fight with the tumor cells. This immunology of cancer consists of tumor antigens and as well as tumor immunology as well as immunotherapy. Coming to tumor antigens are further grouped into two categories. One is the tumor-specific antigen and tumor-associated antigen. Tumor-specific antigens are the antigens which are found only in tumor cells but not on the normal host cells. So we can give an example of breast carcinoma antigen, which is found only in breast carcinoma. It is not found in normal cells. So this can be an identification process. Then coming to tumor-associated genes, these are the genes or the antigens which are found on tumor cells as well as on the normal cells. These presence of this antigens can give an indication that the tumor cells have been completely differentiated, that is, they are completely matured. That is, tumor associated genes represents the stage of a tumor. So the most highly sensitized cells, that is the CD8 cells, are the cytotoxic cells which can be observed. Coming to the immune response to this tumor host, that is, it can be mediated by cell mediated, humoral mediated, or otherwise which is an antibody dependent mediated. Coming to the cell mediated, that is which is being mediated by the macrophages or the natural killer cells, or otherwise the neutrophils, various other cells, interleukin cells or the cytokines, which try to mediate a host immune response against such tumor cells. Whereas in humoral mediated, they do not find any such directly cells which have an effect, but rather they are being antibody mediated or cytotoxic dependent response which can be seen. So these cells usually normally function, but what happens in a tumor associated environment is these cells might have been immunosuppressed because of the tumor, or otherwise they might have been lack of this tumor, absence of this tumor, or otherwise they might have been increased levels that they cause self effect, that is, they might affect their own cells, like the cytotoxicity of the T lymphocytes might cause auto effect on its own cells. So these might occur during the these are the properties which might have occurred the failure of the host immune response to act on the tumor cells. This is what happens in immunology of the cancer. And coming to the next set is immunotherapy. There have been many immunotherapies which have been brought. Presently is chemotherapy and radiotherapy, which are usually drugs which are being used to fight against these tumor cells in chemotherapy, whereas in radiotherapy, radiations are being passed to the sorry. In radiotherapy, we find that the patients are being exposed to radiations which cause the damage of these tumor cells. These are the recent advances in immunotherapy which has been exposed to the host in patients sustaining with this cancers. This explains the tumor-host interrelationship. Coming to the symptoms, usually what we find in a malignant tumor, usually we find that the region, the target area after the metastatic tumor has developed is the regional lymph nodes. That is already explained in cases of metastasis. They usually try to attack the regional area of lymph node, as in breast cancer, the axillary lymph node. Coming to the lung cancer, thyroid cancer, it could be the lateral cervical lymph nodes, or the lung cancer to the supraclavicular lymph nodes, virtuous lymph node metastasis. So based on this, we can say that lymph nodes are the target organs in metastatic tumors or the malignant tumors, whereas in benign tumors we do not see such harmful effect. That could be, or rather it could be only an aesthetic effect. The patient might not be comfortable because of an outgrowth or the external growth of a tumor. The most common symptoms are seen in the lungs, liver, brain and bones. So when these symptoms include in the lymph nodes, that is, they bring the enlargement, and this is known as lymphadenopathy. And in lungs, they cause the cough, the hemoptysis and dyspnea, that is difficulty in breathing, and coughing of blood, sputum can be seen. And coming to liver, that is hepatomegaly, that is enlargement of the liver, and nausea, vomiting sensation and jaundice can be seen. Whereas in bone, we see because of the enlarging tumor, it may cause the bone fracture because it crosses the vicinity of the cortical bone and results in bone fracture, and ultimately results in bone pain too. And then brain, when meninges and the medulla, or the otherwise the central nervous system is being involved, then it can cause seizures or the epilepsy, headache or vertigo. These are the complications we can see and the associated signs and symptoms involving in a particular organ. Coming to the diagnostic aids, for a tumor to be identified, it is important that the diagnostic aids should be mentioned. Among them, the most commonly used is histological method. That is, when a biopsy is being brought to a laboratory First, it is being a gross specimen can be identified as previously mentioned. The borders and the associated secondary changes help in distinguishing it from a benign and a malignant, but is not a confirmatory change, because proper observation of the microscopic and cytomorphological changes under a microscope only help in driving to a diagnosis, whether it is a malignant tumor, mixed tumor, benign tumor, or a potentially malignant tumor. So histological methods help in identifying, that is microscopic appearances help in identifying giving the proper diagnosis. Coming to the cytological methods, they could be exfoliative cytology or fine needle aspiration cytology. Exfoliative cytology, that is, it is being brought by scraping of, suppose it's a buccal cancer, so scraping of the cells can be done, and these scraped off cells, that is exfoliated cells, are being stained with a specialized stain known as pap smear. This smear helps in identifying and differentiating the normal cells with the mutated or the morphologically altered cells, with the help of showing the anisonucleosis pleomorphism features which have been explained in the previous slides. So based on this, it can be given a rapid diagnosis of existence of malignant features, but there is not an accurate diagnosis, that there could be any bias in the diagnosis features. And FNAC, usually a tumor, it is being infiltrated with the help of a force bore needle is being inserted into the area of the tumor and being aspirated. The contents are being aspirated and they are being spread, and similar staining with the hematoxylin, eosin, or otherwise a pap smear, or the various other specific stains can be used to identify what the basis is found in the altered cells, mutated cells, which can help in diagnosis. And coming to the histochemistry and cytochemistry, they are usually, as the name itself suggests, they are such histochemical, that is the tissue along with its chemical composition and the cell along with its chemical composition are being identified, such as that is per-iodic Skiff stain is being used to identify the basement membrane, which helps in identifying the specific basement membrane region. And the cytochemistry, that is, it can be used with the specific enolase enzymes, otherwise protease enzymes, which help in identifying the particular constituents of the respective malignancies or the benign tumors, and presence of these enzymes, that is a positive staining for these enzymes, helps in driving that the tumor is a specific origin. This is what is histochemistry and cytochemistry. Coming to immunohistochemistry, it is an antigen-antibody complex interactions, that is particular antigen in the tumor is being stained with an antibody, that is an artificially synthesized antibody is being exposed to the antigen, and the further staining with the chromogens brings the specific expression of the required component in the tissue. Like say, as explained, the microvascular density can be a proper diagnostic aid for the staging of a tumor. So presence of increased number of microvascular which is being stained with the immunohistochemical markers such as CD34 can explain us in what stage the tumor is, whether it is a well differentiated, moderately differentiated, or poorly differentiated tumor. This is what happens in immunohistochemistry. And for the epithelial cells, S100 could also be used, where it stains the Langerhans cells and the melanocytes. So these are few immunohistochemical markers which can be used in identifying the presence of particular antigens in that tissue, which can help in driving to the diagnosis. Since certain malignancies, certain benign tumors have a particular pathogenic mechanisms, so these pathogenic mechanisms can be identified by immunohistochemistry. Coming to the electron microscopy, since by basic microscope, light microscope, all the structures cannot be identified, so electron microscopy is such structure which helps in identifying the microscopic levels at the ultrastructural and histochemical levels, such as the intercellular junctions, which cannot be usually observed in electron microscopy, can be observed by by light microscopy, cannot be observed such as microscopic features, such as minute structures, which could be intercellular junctions or the cytokines or the fibrillar elements, which cannot be observed by the general light microscopy, can be observed in electron microscopy. This also helps in observing, acting as a diagnostic aid for observing into, driving into a diagnosis of a tumor. Coming to tumor markers, these are the markers which help in identifying particular presence of a particular antigen or otherwise an enzyme. They could be oncofetal antigens or otherwise embryonal antigens or otherwise enolase specific antigen or otherwise a protease antigen. There could be chemical antigens or otherwise the embryonal antigens, which can be seen, or otherwise bone antigens also can be seen, which specifically mark the bone forming cells. This is what is tumor markers. So they help in identifying when this particular tissue is being stained by these markers. The expression of these helps in indicating that the tissue is of certain origin, of a particular origin, which helps in driving us to only to a set of tumors. That is, it could be a benign tumor of certain origin. Coming to if the presence of tumor marker of something related to bone, osteoclast, is being observed, then we can drive only to the bone tumors showing the expression of osteoclast, which helps in concising the amount of tumors and helping to driving to accurate diagnosis. This is what is tumor markers. This finishes the diagnostic aids. Other than this, advanced diagnostic aids such as in situ hybridization, which helps in identifying the DNA sequence, and otherwise microarray analysis, which uses the help of gene chip to see the sequence of DNA arrangement and the alterations in at the genetic level can be identified. So there are various advanced techniques which have been introduced for diagnosis of tumors. Coming to the grading system, it is very important to differentiate a tumor. Once it has been diagnosed as a tumor, it is not only important, but it is important even to know at what stage the tumor is. So the most commonly used grading system is the broadest grading system, which differentiates a tumor into 4 grades. Grade 1, which is a well-differentiated tumor, which consists of less than 25% of anaplastic cells. Anaplastic cells, that is the mutated cell features or the damaged cell features or the dysplastic cell features. As explained, it could be anisonucleosis, polycyclosis, or otherwise loss of basal polarity or abnormal mitotic figures. These all include the dysplastic or the anaplastic features, that is loss in the resemblance for that of the parent cells or the neighboring cells. Grade 2, moderately differentiated, which could constitute 20 to 25% of the anaplastic cells. Coming to moderately differentiated, it could be a well moderately differentiated or poorly moderately differentiated. So coming to the grade 3, that is the moderately differentiated cells, which constitutes of 50 to 70% of anaplastic cells. That is approximately, that is the dysplastic cell percentage is 50 to 75%. Coming to grade 4, that is poorly differentiated cells, that is more than 75% of the anaplastic cells can be observed when we have taken a tissue section. Usually broadest grading is based of taking a particular tissue section, especially at the area of the breach, that is where the tumor has been invading into the underlying mesenchymal tissue from the epithelium to the mesenchymal tissue. So broadest grading can be applied only to the area where there is invasion. So these are the grades, 4 grades of broader grading system. Coming to the staging, there are 2 types of staging which have been described. First one is the TNM staging and the ASJC staging. Both these staging systems are based on the degree of differentiation and the rate of anaplasia. So the TNM staging system, as the name denotes, T stands for tumor size, N stands for nodal metastasis, M stands for metastasis. That is T0 to T4. It includes, that is absence of tumor to tumor which exceeds 4 centimeters in size. This is what is means. T0 is absence of tumor in the site. TX means TX is in situ. TIS means in situ in lesion, and T1, that is less than 2 centimeters of the tumor size. T2 to 2 to 4 centimeters of the tumor size. T3. So T0 mentions that there is no tumor. TIX means carcinomancy, that is tumor is present only in a particular lesion which does not extend beyond the epithelium. And coming to T1, it is a tumor of less than 2 centimeters. T2 2 to more than 2 centimeters, and T3 2 to 4 centimeters, and T4 that exceeds 4 centimeters in size. This is what grade C tumor size from T0 to T4. Coming to the nodal metastasis, there is N0 to N3, that is non-nodal involvement to widespread involvement of the node. It could be ipsilateral or bilateral. Coming to M0 to M2 metastasis, that is a metastasis which could be range from no metastasis to disseminated hematogenous metastasis. Coming to AGC, that is according to the American Joint Committee, they have staged it into stage 0 to stage 4, which could again constitute of T and M staging in this. So this finishes the staging and grading of the tumor metastasis. Thank you.